DOI is not in this depth
First
of
stage.
image.
Now what, Amit, you were very right in coming back to me on regarding various inputs. That was wonderful. Nowadays, like we discussed already for ERP, now DOI is mandatory in all oral cancers, head and neck cancer. Now with DOI, they would like to change and plan this. In first case, we will share with you. So if that could be incorporated in the standard of...
In fact, that is something we even observe, but we often forget to write. That is all.
I agree with you completely. Sometimes you do right. So DOI is in a way mandatory to it. Because staging has changed. Based on DOI, they stage now. Now the staging for head and neck cancer is moved from those related to HPV and those without HPV, those two groups, totally different behavior, and DOI and number of nodes. The other thing was, second one, we had a case of carcinoma of breast in that grandmother of a elderly, 78-year-old lady, which was ERPR negative, which we don't disagree with because it's very aggressive, and HER2 positive. So she's come back within 3 months. We did not give any therapy because she was very old and not willing. So now she was weekly positive PR. We are hanging by that thread only. So if we have sent a new biopsy, we can get the ERPR
We can do it
again. Although it is KI 67, more than
60 to 67.
Very highly unlikely.
Highly
If such a high case,
I agree.
to be PR positive.
Unlikely. And the third was a case of papillary carcinoma of thyroid where we did total thyroidectomy. And now probably yesterday we got the report and it's medullary.
Medullary carcinoma.
That will lead to
And
really
that, I remember Dr. Sachin was telling me of that case they saw during the intro.
They were there in the date of frozen.
Frozen, and he was suspecting probably anaplastic.
Yes. That they were all very interested in.
So that medullary must have been IHC? IHC क्या वो report?
They have not started reports.
IHC नहीं किए.
अभी they put on
IHC के बगैर तो फिर कहना मुश्किल है.
No, I think वो कर रहे थे ना. We are doing that, but this is one more case where we will be interested.
In fact, I was telling Dr. Sachin that with that kind of intraoperative picture, it might be a case of medullary, but which has undergone anaplastic transformation.
That's what I was
so
telling you.
we need to sample it extensively. We are missing that area. That I told him to take more sections.
I
from
think you
other
look
areas.
into it yourself and
I'll see
maybe
the slide.
it will make a huge difference. Because if it is medullary, we have no modality available. We'll have to go in again or do some EBRT or some kind of a, airy-fairy thing. But if it is papillary, then we have a good chance of providing radioactive iodine.
Papillary and medullary, so we are able to differentiate.
No, I'm not saying that papillary with that kind of a poor differentiation sometimes can be a confusion.
Right.
I'm talking about not the usual
Not
papillary.
usual.
You don't get to see those Samoa bodies
Yeah.
and nicely smiling cells.
Not a
Those
typical
kind of
case.
It can be a challenge, especially with anaplastic.
I'll see the slide. I have not seen the
Yeah,
slide.
yeah, that's the thing. These are the 3 points that we wanted to